A very good morning, everyone. Kochs or Sarles, two distinct identities, but they yet appear to merge seamlessly. Let's dissect and find out how. So, one fine morning, a mysterious case walked into our OPD, vexed with this prolonged duration of redness and severe pain. He was a 26-year-old male who had diagnosed with extrapulmonary Kochs 4 years ago and was treated with tubercular medications, and now presented with redness and pain 4 years later. He was diagnosed with right eye nodular scleritis elsewhere, started off with a visual acuity of 6 by 9. With the backdrop of ocular tuberculosis, he was started on ATT elsewhere, with the evidence of ACT TAP being positive from MPB64. We did an ultrasound by B scan, and he found a choroidal elevation with scleral thickening and subtenous fluid. He was continued on the ATT medications, yet the vision worsened from 6 by 9 to 6 by 60. The retinal examination also showed a right eye subretinal tubercular abscess-like picture and was thus treated with intravitreal antibiotics. He did not improve at all and was advised enucleation and then came to us. A diagnosed case of ocular tuberculosis, visual acuity as low as no light perception, developed complete ophthalmoplegia while on treatment and showed no signs of resolution. He had right eye volume loss, however there was no enophthalmos. This mandated an orbital imaging to rule out the orbital mass underlying. The diffuse tissue enhancement covering the entire orbit was seen on the MRI. Then there was also an encasing component along the optic nerve involving the right eye lacrimal gland as well. The right-sided proptosis and the diffuse swelling also caused compression, distortion and infiltration of the globe. On the basis of clinico-radiological judgment, we gave a steroid washout period for 3 weeks and conducted a multi-level incisional biopsy. On histopathology, found a marked lymphocyte and plasmacyte infiltration. Putting the 4 Gs together, a growing mass with granulomatous inflammation, infiltrating the globe completely and then responded to glucocorticoids. These Gs brought together and also supplemented with the IHC being positive for more than 55 IgG4 plasma cells and raised serum IgG4 levels. As all the 3 criteria of clinical, hematological and histopathological were confirmed, we diagnosed the patient with definitive IgG4 related disease. We went on to treat him with a repeat of steroids at a dose of 500 mg with a loading dose and a 3 weekly cycle of maintenance dose, and an addition of 1 gram of mycophenolate mofetil at the 4th cycle of IVMP. He showed dramatic results with significant improvement of symptoms and decrease in the pain and redness, and an MRI was also repeated which shows resolution of the proptosis and the enophthalmos set in. Once stable, we went ahead to do a right eye enucleation and also did a tarsofrontalis sling, achieving a good cosmetic and functional outcome. IgG4 related disease has been reported to occur during the TB contact or after TB confirmation. When done a review of literature, our patient was relatively had a younger presentation and similar treatment has been practiced among the other studies as well. Here in front of you are the pole-to-pole manifestations from the anterior to the posterior, where multiple differential diagnosis has to be kept in mind. But with the help of clinical, histopathological and radiological diagnosis, we can diagnose this disease and finally come to a conclusion. This disease mimics a broad spectrum of clinical entities ranging from neoplastic to inflammatory, yet early diagnosis and treatment aids in an excellent outcome. Thank you.
Ashwitha, in one slide you said that you suspected subretinal tuberculosis.
Yeah,
and then you treated with intravitreal moxifloxacin.
Yes, that was not in our setup. That was all done elsewhere, and then he came back to us. Like when they were treating with anti-tubercular medications, they found some retinal exudates, and they thought that was subretinal abscess. These are the images that he collected from elsewhere and came to us.
Good case.